Makwa, and I will be hosting this session that we're having today, the Botswana COVID-19 webinar session 15. I will be co-moderating with Dr. Gontse Tshisimogo. She will be joining me a little later as we go along with the program. So I'd like to take this time to actually welcome everybody to our session today. It's our number 15. This is something to celebrate. We've been together sharing this information, guidelines on how to manage our COVID patients, and many other aspects of the cascade of care. And today we are very happy to be with Professor Jarvis, who will be taking us through the updates that have been made to the guidelines, to the COVID-19 guidelines. Just for our housekeeping announcements, just a reminder to all of us that this webinar series are co-organized by Ministry of Health, the University of Botswana, the Botswana-Harvard Partnership, and Rutgers University. And for those of us who are joining us and have not necessarily received an email invite from us directly, we would like to add you to our database so that next time we can send the invites to you. Just send your request to that email address that you see there. And we would like to remind all of us who are participating in this to mute our mics throughout the presentation. We will have a session where we will have questions and answers, and that is the time when we will unmute our mics. Please use the chat function to post your questions to the presenter, and these will be monitored by both the presenter and others who are assisting him in the background. Feel free to ask the questions that you may not want to ask during the Q&A session. We record all our sessions. The previous ones that have been recorded have been uploaded on our YouTube page, which the link will be shared later, so that people can actually visit this page and be able to listen to the previous sessions that we've had. After our session today, we will send you an email that will have a set of questions just for you to give us feedback on how you think that the session went and what are the areas of improvement that we think we should pay attention to. In terms of the layout or the overview of our session today, we will have the presentation by Professor Jarvis, and then from then we will have our question and answer session, which should last us about 15 to 20 minutes. And Professor Jarvis will be joined by two doctors, Rebecca and James, and I'll talk a little bit about them in a short while. And as I said, my co-moderator is Dr. Gontse Tshisimogo. From here, she'll be the one who takes over, especially when we go through the question and answer session. Now, today it's my privilege, ladies and gentlemen, to introduce our speaker, a very well-known Professor Jarvis, who has contributed immensely in the COVID response here in Botswana, insofar as the write-up of guidelines is concerned and giving guidance to clinicians across the country. Professor Jarvis is a professor of tropical medicine and international health at London School of Hygiene and Tropical Medicine. He is based at Botswana-Harvard Partnership here in Gaborone. He has lived and worked in Botswana for 7 years now. I'm pretty sure he must be eloquent in Setswana by now, and has been involved in multiple high-impact clinical studies that have informed policy guidelines both locally and internationally. Professor Jarvis is co-chief investigator of the Ambition trial, which is the biggest ever trial, a clinical trial conducted in the field of HIV-associated cryptococcal meningitis, and is recruiting participants in 8 hospitals across 5 countries in Southern and Eastern Africa, including Princess Marina Hospital. Professor Jarvis is also a recipient of the NIHR Global Health Professorship that focuses on reducing mortality associated with the central nervous system infections in Southern Africa. It is our privilege to have you, Professor Jarvis, taking us through this presentation today. And just as a brief, he will be joined later on by James Melbourne, who is an infectious disease specialty trainee from the UK, who first came to Botswana in March, but returned to London to support the COVID-19 response there. James has since returned to Gaborone, where he is working with Professor Jarvis as the research fellow. And then we also have Rebecca Ryan, who will also join them during the Q&A session, who has completed her internal medicine training in the UK and moved to Botswana last month to work with Dr. Moroni at BHP. Rebecca spent a considerable time caring for COVID patients as well over the last few months, particularly those in intensive care units in London. It is our privilege to have James and Becky, who have extensive hands-on experience looking after COVID patients, and we look forward to learning from them as well. So ladies and gentlemen, do join me as we welcome Professor Jarvis to the virtual stage. Professor Jarvis.
Thank you very much, Robert, for that extremely kind introduction. I wasn't expecting quite so much detail. Thank you. And thank you everybody for joining the session. I hope it's going to be useful. Thank you to James and Becky for joining. And also, I think when we get to the question and answer session, I'll call on Dr. David Lawrence, who's been very instrumental in writing these guidelines as well, and Dr. Tommy Pillai, who's really been at the coalface running things at Ketamile Mesire Teaching Hospital to address some of the questions. So I'll just share my screen now. And hopefully you can now see the slides up on your screen there. So Robert's already been through the introduction to the webinar series here. Let me just change that to the slideshow view. So I'll skip that, just to say that there is a YouTube channel. All of these talks are recorded and you can go and watch previous talks or go back through this talk on the channel. The details are there. It's the Botswana-Rutgers Partnership for Health YouTube channel, and you can find the Project Echo COVID-19 videos there. And also to mention that on the Ministry of Health and Wellness COVID-19 portal, you can find a lot of information here, including if you click on the document library, copies of all of the guidelines that I'm going to be discussing or talking about today. So if you want to get copies of any of the guidelines that are being used nationally in the COVID response, you can go to that dashboard, click on the document library tab, and that will take you here, and you can download the latest copies of all of the guidelines to go through in detail. So what I'm going to do in this session is go through a quick overview and update of some of the guidelines, really just trying to highlight the recent changes that have happened and things that are particularly pertinent now that case numbers in Botswana are starting to increase relatively rapidly. And I think many clinicians are starting to or have already seen some cases. And of course, we're likely to start seeing more sick and unwell patients who are going to need looking after. Once I've finished the talk, I think we can move on to questions and answers from all of you who are listening today. And I think particularly if people have any clinical questions or queries about managing these patients in medical wards or the intensive care setting, then James and Rebecca would be very well placed to answer those. And then we can move on to the discussion Q&A and some of the questions that have been sent in and any that are put on the chat. And I'll answer those with help from Tommy Pillai and David Lawrence and of course, Drs. Milburn and Ryan. So going through the guidelines, there are a number of guidelines that I wanted to touch on. The first one was personal protective equipment, because there's been a bit of, well, we get questions about this, and I think people need some reassurance about what the right thing to do is. So we've split the guideline up into different situations, and just going through some of the main ones here, we've got recommendations for patient screening, for patients, carers who are actually taking swabs or looking after unwell patients, and for those who are doing aerosol generating procedures, which are all slightly different. So for patient screening, so this is at the front door effectively of hospitals or healthcare centers where patients are coming in, and we're trying to ascertain whether they need to be sent for COVID testing or whether they can be released to go into the healthcare facility. We recommend simply that physical distance is kept of 2 meters. Plastic screens could be used between the person screening and the patient, but if that isn't possible, then it's simply goggles or a face shield and a medical or a surgical mask. For clinicians who are collecting respiratory samples, so these are now people taking a swab from cases or from suspected cases, or caring for or transporting a suspected or confirmed case, we move on to the next level of personal protective equipment. So this is eye protection with goggles or a face shield. Again, it's a medical or surgical mask. All of the data suggests that an N95 mask is not actually necessary and that medical or surgical masks are adequate if worn properly. There's quite extensive data from settings in Europe now looking at this, particularly the UK, where infection rates using medical masks or N95 respirators are not really different. Medical masks seem to be adequate. A gown and gloves. Only in the setting where people are caring for suspected or confirmed cases and doing aerosol generating procedures, such as intubating patients or looking after intubated patients. Then we move up to the highest level of personal protective equipment, which is goggles or a face shield for eye protection. Now it is a respirator mask, which is an N95 mask or an FFP2 or 3 mask. They're basically equivalent. An FFP2 filters 94% of particulate matter below 5 microns, and N95 filters 95%. So they're almost equivalent, gown and gloves. So those are the current PPE guidelines, which are across those recommendations are consistent across all of the other guidelines. The next guideline I briefly want to touch on is guideline number 3, preparing a healthcare facility for COVID-19. And I think this is of particular importance given recent events at Princess Marina Hospital, where there have been a number of positive cases and there were some potential issues with transmission within the healthcare facility. So this guideline can be summarized in this rather busy table, but I'll take you through this step by step each section so we can just follow what's happening or being said here. So the first section of this is a screening questionnaire trying to determine whether the patient meets a case definition for suspected COVID-19. So all individuals who are entering the premises should be screened, and it should be determined whether they meet this case definition for suspected COVID. And you can see the boxes there. It's a patient with an acute respiratory illness, onset of at least the following: cough, sore throat, shortness of breath or fever, and any history of travel outside Botswana or to a location within Botswana reporting community transmission during the last 14 days. A patient with acute respiratory illness and having been in contact with a suspected probable or confirmed case, or a patient who's hospitalized with a severe acute respiratory illness. Now, I think the important thing to note is that at the current stage in the epidemic, we now have community transmission of COVID-19 reported across most of the country, certainly across the whole of the Greater Gaborone area. So basically, we're in a situation where any patient presenting with an acute respiratory illness or symptoms suggestive of COVID-19 should be considered a suspect regardless of their travel history, and they should be tested. So I think it's important just to note that is a change really as the situations evolve. So really we have to consider in this setting now anybody with compatible symptoms as a suspected case, and of course anybody who's been in contact with a confirmed case will be screened by the contact tracing teams. So if somebody meets that case definition for a suspected case, in other words, they've got any of those symptoms, then they should be isolated and triaged. They should be given a face mask and sent to a place away from other patients and other members of staff or the public, where they should be assessed by a healthcare worker. If that healthcare worker determines that they are indeed a suspected case, then at that point we need to notify the DHMT and move on to sample collection. If they don't have any of the symptoms or they don't meet the definition for a suspected case on assessment by the healthcare worker, they can be given a slip and allowed to proceed into the healthcare facility for that day, but the screening needs to occur every day. How do you get suspects tested? Well, all suspects need to be tested. You've got two options. One is that you can collect the sample yourself if your facility has the swabs to enable you to do that. Of course, the hope is that more and more facilities will have access to the swabs and be able to do the testing directly without having to call the DHMT. But if you're in a setting where you don't have access to the swabs to take the samples yourself, then you can call 997 and arrange testing, or call your local DHMT directly if you have the number. The samples to be sent are still nasopharyngeal and oropharyngeal swabs. There's a lot of interest in doing testing on saliva as it's a much easier specimen to collect, and there's increasing data that the sensitivity of testing saliva is probably nearly as good as doing the nasopharyngeal and oropharyngeal swabs, but we're still not quite at the position of having enough evidence to include that in the guidelines yet, but it is being investigated in various studies that are being run at the teaching hospital and hopefully soon at the national, at the Botswana-Rutgers laboratory. Samples are sent for real-time PCR testing, which is the gold standard test. We're not using any antigen testing at present in Botswana, and antibody testing doesn't really have any role in testing of acute cases because it takes several days after a patient becomes infected and even develops symptoms before they mount a detectable antibody response, often a week into illness. So it's PCR testing to detect the RNA of the virus. The sensitivity of this is about 70 to 80%. It depends, of course, on a huge range of things, ranging from that sample being taken properly to it being transported properly to the lab doing the test properly. But even if all of those things are done correctly, the sensitivity is not 100%. You can expect false negatives. So the message from that is that if you have a patient in whom you strongly suspect has coronavirus, don't allow just one negative test to put you off the diagnosis, to say that you've ruled out infection. You should certainly repeat the testing because it is possible that you'll miss cases. Imaging may strongly suggest coronavirus before the test is positive. So if you do a chest x-ray in somebody who's got a compatible syndrome and you see chest x-ray changes, that's strongly suggestive of coronavirus, particularly as the cases are increasing. Very quickly, just to run through testing, I think most of you will have seen this before and been familiar with it, but this is the equipment that you need for testing. So these are not cotton swabs. These are flocked swabs made out of various types of plastic. Cotton and wood swabs inhibit the PCR test and can't be used for this. And universal transport medium to send the swab in. It's not actually that critical that you use universal transport medium if testing is going to be done very quickly, but we have it here and so we use it here. Tongue depressor, you need your personal protective equipment, disposal equipment and so forth. So how do you do a swab? Well, you make sure you're wearing the correct PPE. For the nasopharyngeal swab, you open the narrower of the two swabs on the long stick, get the patient to tilt their head back, and you can see here that you're not pushing the swab upwards in the nostril, up towards the eye or towards the brain. You're pushing it straight in, back towards the patient's ear effectively. And you can see that you want to get it right into the nasopharynx, which is quite far in. So you push it back, going straight in, making sure you're not aiming up until you get gentle resistance. And then once you get resistance and can feel you're at the back of the nasopharynx, you rotate the swab a few times and then withdraw that, break off the shaft, close the tube and send it. The oropharyngeal swab is something that people are much more familiar with. So effectively, it's just opening the patient's mouth with a tongue depressor, putting down the tongue, and then swabbing the posterior pharynx in a figure of 8 movement. You'll often get a gag reflex that tells you that you're, well, that you've gone to the right place, but you can try and avoid that by avoiding the soft palate and the tongue. And again, place the swab in the transport medium, break the shaft and send the sample to the lab. So quite straightforward. Tightly close the tube. If you're transporting it, you can place it in a biopack or a cooler box. Make sure that everything's labeled properly, remove your PPE, wash hands with soap and water, and arrange transport to the facility. In the event that you've got a suspected case of coronavirus, if you're trying to determine how you manage the patient, the first step is to determine severity of disease. So this is in several of the guidelines, but mainly in the clinical guidelines. So how do we determine disease severity? Well, if they meet all of the criteria in the box on the top left, in other words, oxygen saturations of 95% or greater on room air, respiratory rate of less than 25, heart rate of less than 120, temperature of less than 39, normal mental status, age less than 50, and no comorbidities, then we would consider them a mild case. Initially, all cases were being managed in the teaching hospital or in healthcare facilities, but as the numbers have increased, the guidelines have changed, and so now it's viewed as acceptable to isolate some of the mild cases at home under the supervision of the DHMT, but the DHMTs will make that, or help make that assessment with you, but it's based on your assessment of whether the patient meets all of those criteria for having mild disease, and also whether they are capable of home isolation. In those who have moderate or severe disease, and so that's in anybody who has oxygen saturations of less than 95, a respiratory rate of greater than 25, heart rate greater than 120, temperature of greater than 39, abnormal mental status, or those who are over the age of 50 or have comorbid conditions, currently the guidelines suggest that they should be admitted and isolated in a hospital. This will happen before the patient has had their test results. So if the patient tests negative, if you have a strong clinical suspicion, then of course you want to retest the patient. But if you're convinced the patient is negative, then they should continue isolation for 14 days if they have been in contact with any known coronavirus cases, which they may have been if they've been cohorted on a ward with other coronavirus cases. Just moving on, in those who have a positive test result, what do we do? Well, we transfer those to a confirmed COVID-19 cohort area and continue in-hospital isolation and management. At the moment, the majority of patients are being transferred to Sir Ketamila Masire Teaching Hospital for treatment, but as case numbers expand and increase, I think it's reasonable to assume that nearly all healthcare facilities, at least the secondary level hospitals and tertiary level hospitals in the country, will be needing to prepare cohort areas where they can transfer and look after coronavirus cases, as it will become impossible to send everybody to the teaching hospital as things get busier. When can you discharge somebody from hospital? Well, you can discharge somebody from hospital when their fever's resolved, their symptoms are improving, and there's no clinical indication for admission. But this is different from releasing somebody from isolation. So the criteria for releasing somebody from isolation, so if somebody's very well, they may be discharged from hospital for home isolation, but before you can release somebody from isolation, they need to meet the criteria. And these criteria have been updated based on accumulating evidence on the 11th of August. So previously what we were doing in Botswana was we were waiting for the patient to have 2 negative swabs before we could release them from isolation, 2 negative PCR tests. However, there's very good evidence that people shed dead virus for an extremely long time. So people shed detectable viral RNA for 3, 4, sometimes even longer weeks after infection. However, if you try and culture the virus and look for viable or infectious virus, you find that that's nearly all disappeared by day 8 after symptom onset. So the RNA that you're detecting is just demonstrating that there's dead virus around. It doesn't relate to infectivity. And it means that if we use that criteria, we would be keeping far too many people in isolation for far too long. So on the basis of that updated evidence, the criteria for release from isolation were changed relatively recently and are now, if a person is asymptomatic, then we can release them from isolation 10 days after their first positive PCR test. If they're symptomatic with mild disease, we can release them from isolation 10 days after the onset of their symptoms. If they have moderate or severe disease, then we can release them a minimum of 10 days after the onset of symptoms and at least after 7 days without receiving supplemental oxygen. So I hope that's clear. So in asymptomatic individuals, those who've just had a positive test, in other words, been picked up through contact tracing or screening, they can be released from isolation 10 days after the first test. In those who have symptoms, if it's mild, you can release them from isolation 10 days after the onset of symptoms. If they're moderate or severe, at least 10 days and at least 7 days without receiving oxygen. Moving on to the clinical guidelines. This is really duplication and just repeating a bit of what I've said before, but I think it's worth making the case because all clinicians at all healthcare facilities around the country need to be prepared for this now, as cases are likely to start increasing in the community and presenting to hospitals. So we need to rapidly triage the suspected cases. A severity assessment is essential using those criteria that I outlined. Mild cases can be managed outside of hospitals in isolation facilities or at home, depending on the latest guidance from the Ministry of Health and Wellness. But those who are triaged as moderate or severe need to be admitted to hospital. And of course, a proportion of mild cases will worsen and become moderate and severe cases. So those ones who are triaged as being mild and sent home need to receive monitoring from the DHMT teams such that if they do become unwell, they can be admitted to hospital. We've been through this already, the criteria for a mild case, but how do we decide who can isolate at home and who needs to be in hospital if they are mild? Well, you have to be able to self-isolate safely. So that involves both having a separate room with a private bathroom available either in your home or isolation facility, and a patient who's well enough and understands the situation well enough to be able to return to a healthcare facility if they become unwell. And they must not be at risk of clinical deterioration based on age or comorbidities, as I mentioned earlier. What investigation should we do in our coronavirus cases or our suspected coronavirus cases once they've been admitted to hospital? Well, a full blood count, which may demonstrate lymphopenia and thrombocytopenia, which are quite typical of viral infections. Electrolytes and renal function to check for acute kidney injury, which is a poor prognostic sign. Liver function tests, you may see some elevated transaminases and bilirubin. CRP, LDH, ferritin, and D-dimers can all be raised. They're not really tests that we do routinely in our setting anyway, but just in case you do, then be aware of that. Of course, we need to think of all of the usual things. So HIV testing should be routine in anybody who doesn't know their status. CD4 count and viral load as indicated. We need to be aware that there may be other co-infections or that there may be a different diagnosis altogether. So blood cultures, and if a patient is very unwell and you're needing to assess their respiratory status, then arterial blood gases. Exclude other diagnoses using what would be standard diagnostics in this patient population. So throat swabs, sputum microscopy, sputum for gene expert ultra for tuberculosis, urinary Legionella antigen not really available in our setting, urine dipstick and culture, ECG, just your usual tests. Do a chest x-ray. You'll often see chest x-ray changes in patients with coronavirus, and perhaps Doctors Ryan and Milburn can comment on what they saw in the UK at the end of the talk here in these typical cases. This is a picture of somebody who's rapidly progressed to having ARDS, and this is a CT scan of the patient. Management, what do we do? Well, the most important thing, or one of the most important things we can do, is give oxygen. It's the single most effective supportive measure. We'd give it if the SpO2 falls below 90% in adults and children, or below 92% in pregnant women, which are in the adult pediatric and pregnant women guidelines. Once commenced on oxygen, we aim for saturations of 92 to 96%. Don't over-oxygenate, as this can be associated with harm. And we can titrate oxygen using different delivery systems. The first step would usually be nasal cannula. This gives a relatively low fraction of inspired O2 of 0.25 to 0.4%, but will be enough in many patients. If that's not working, then we could move to a simple face mask with high flow oxygen of 6 to 10 liters a minute, which is increasing your FiO2 to 40 to 60%. And finally, we could use a face mask with reservoir bag, O2 flow rate of 10 to 15 liters a minute. And this is, of course, prior to or before we start talking about intensive care treatment and ventilation of any sort, either positive pressure or full ventilation. Fluids, use conservative fluid management. We don't want to be too aggressive with fluids and cause pulmonary edema. Manage shock as you normally would with small boluses and reassess after each bolus rather than just writing up 1 liter bags and running them in quickly, and monitor fluid balance carefully. Vasoactive agents, well, this is really now getting into the intensive care management, which is obviously quite specialized, and I don't want to talk about too much, but just briefly in the guidelines, we say to aim for a mean arterial pressure of 60 to 65 millimeters of mercury. Only start vasopressors once confirming that patients are fluid replete. We'd use norepinephrine as our first line vasopressor. If poor perfusion and or cardiac dysfunction persist despite achieving the mean arterial pressure target with fluids and vasopressors, consider an inotrope such as dobutamine. Antibiotics. If there's any clinical suspicion of co-infection, then consider antibiotics. What we'd recommend in the guidelines is to treat suspected or confirmed pneumonia with coamoxiclav 1.2 grams IV TDS for 7 days and azithromycin 500 milligrams once daily for 7 days. However, of course, as we know, our antibiotic choice here is determined by availability, and we may not have access to those. If not, then ceftriaxone and cefotaxime is an alternative which is widely used here. This is one of the key messages which is new, I think, from the first time we gave this talk. We've now had convincing evidence from very large randomized controlled trials, the recovery trials, showing the benefit of steroids in coronavirus, particularly dexamethasone. And what the recovery trial showed, which was a large randomized controlled trial in the UK, was that steroids had most benefit in the most unwell patients. So in ventilated patients, steroids made a major difference to mortality risk, a considerable reduction with a hazard ratio of about 0.65. That's a 35% reduction in mortality, which is quite significant in that patient population. In those with moderate disease, in other words, those who were requiring oxygen but were not ventilated, steroids caused about a 20% reduction in mortality. But in those with mild disease, in other words, those not requiring oxygen, steroids didn't have any mortality benefit. In fact, there was a slightly increased risk of mortality in those receiving steroids. So as a result, the guidelines are that in people with mild coronavirus, in other words, those who meet all of those criteria that we outlined and are not requiring oxygen, we would not recommend treatment with steroids. In those with moderate disease, in other words, requiring oxygen, or severe disease, those requiring ventilation, then we would give steroids for 10 days, and you can stop earlier if symptoms resolve. And the steroid of choice is dexamethasone, 6 milligrams daily, given either orally or intravenously, depending on what your patient can take. That is the steroid regimen that was used in the recovery trial. So that would be our favored steroid regimen here. If you can't get dexamethasone, then the following are equivalent doses of other steroids, and meta-analyses have shown that these steroids do, the suggestion is that they should have similar effects to dexamethasone and also reduce mortality. Prednisolone, 40 milligrams once a day, hydrocortisone, 80 milligrams IV twice a day, or methylpred, 32 milligrams orally or intravenously once a day. These slides will, as I said, all be available after the talk and on the YouTube channel if you need them for reference. What about other therapies? Well, do not give hydroxychloroquine, chloroquine, or lopinavir ritonavir. We've now got conclusive evidence from multiple data sources, but particularly, again, this large recovery trial in the UK, that hydroxychloroquine, chloroquine, and lopinavir ritonavir had absolutely no mortality benefit. There was no reduction in mortality in the chloroquine or lopinavir ritonavir groups of the trial. In fact, mortality was slightly increased, and no other benefits either in terms of symptom resolution or time to hospital discharge. So those have now been tested. The answer's out there, they don't work. The WHO Solidarity trial is due to commence at the teaching hospital shortly. And what that trial is now testing, it's an adaptive trial, so they drop arms as things change. But what they're planning to test at the moment is interferon beta, remdesivir, and I'm not even going to try and say the name of that last drug, which is a tyrosine kinase inhibitor used for the treatment of various kinds of lymphoma, which is being used as another immunomodulatory agent. So in our setting, those drugs are all just for use in trial settings. I'm sure a lot of you have read about remdesivir. There have been some data released from several trials around the world. And what they show is that remdesivir seemed to reduce the duration of, well, the time to symptom recovery, meaning slightly shorter hospitalizations. but there's still not any convincing benefit of a mortality, convincing evidence of a mortality benefit with remdesivir. So it looks like it almost certainly does lead to some improvement, but it's certainly not the magic bullet that we may have been hoping for. And I think that ethically it's entirely appropriate to use it just in the setting of randomized controlled trials in our setting at the moment. What else should we give? Well, of course, if you suspect PCP, which may be very difficult to distinguish clinically from coronavirus in patients with advanced HIV disease, and give high-dose cotrimoxazole and steroids. Try and keep the hemoglobin above 7 to help with oxygenation and circulation. Targeting higher thresholds doesn't lead to better outcomes in sepsis. And of course, if in doubt, then try and call a specialist, particularly if you're dealing with very sick patients who need intensive care management. This is a picture of somebody receiving prone positioning. So it became apparent from numerous anecdotal reports quite early on in the COVID epidemic in Europe and subsequently the US, that prone positioning, in other words, lying patients on their front, could markedly improve ventilation in patients with severe coronavirus who required intubation and ventilation. But it also became apparent that even in individuals who were not yet requiring intubation and ventilation, putting them in a prone position could achieve much better oxygenation. And perhaps Dr. Pillai could comment in the question and answer session about what's being done regarding that at the teaching hospital. So if somebody is struggling on supplementary oxygen but not yet ventilated, you can try prone positioning and see if that improves their oxygenation. What happens if a patient deteriorates? Well, if their oxygen saturations can't be maintained despite maximal oxygen therapy, then intubation may be indicated. And of course, that's something that you need to contact an ITU physician or an anesthetist to do. Try and do it in good time and do it so it's not an emergency procedure, because those emergency procedures are of course high risk for patients and also a major infection control risk. This is an aerosol generating procedure. This requires the highest level of PPE, and we'd rather do it in a contained fashion. When do we discharge cases? Well, this is just re-emphasizing what I said a bit earlier. So patients can be discharged from hospital, confirmed coronavirus cases, once the fever is resolved, their symptoms are improving, and there's no other indication for admission. In other words, they don't require any supplementary oxygen or any other therapy that they can only get in hospital. However, remember, that is not the same as release from isolation. If they have not met these criteria for release from isolation, then you would step them down from hospital to an isolation facility or home isolation. And those criteria, once again, are asymptomatic infections have to be in isolation for 10 days from their first positive test. Mild cases need to be isolated for 10 days after symptom onset. And the severe cases need to be at least 10 days and 7 days after clinical stability has been achieved, in other words, off oxygen. So that brings us to the end of my slides. And I think very happy now to, with Drs. Milburn and Ryan and perhaps Dr. Pillai and Dr. Lawrence to address any questions that may be on the chat function or any of the questions that have come in. So thank you very much for listening. I'll stop sharing the screen there and go back to the video.
Hello, good afternoon. My name is Gontse Tshisimogo. I am a co-moderator for this session. So thank you, Professor Jarvis, for the presentation. It was nothing short of incredibly informative. So we have received many questions prior to this session. So I'm thinking maybe you can address the questions that were sent prior to the session, and then thereafter you address the questions that were asked on the chat box. So maybe you and your team can take over, because I think we have received close to 50 questions. So, but some of them have been addressed during the presentation. So
okay, fine. So let me try and quickly run through some of the questions that we received before the talk then, and I'll refer some of these on to colleagues as appropriate. So starting with this, it's a long list of questions. So the first one is about whether quarantine is still 14 days. The answer is yes. So quarantine is distinct from isolation. So quarantine is people who've been in contact with a case, and we're now keeping them in quarantine to see whether they develop coronavirus and become infectious. So that stays at 14 days. That hasn't been changed. Is remdesivir available? Well, we touched on that in the talk. No, it's not available for routine use. It will only be used in clinical trial settings in Botswana at the moment. Some of these questions, I should say, are questions I can't really answer because they're geared up to, they're directed at the Ministry of Health and at the policy level there, and I can't really address some of them. So are there customized guidelines yet about dentistry practice from the Ministry of Health? I'm afraid I can't address that question. Gontse, do you know whether that's something that's happening from the Ministry of Health and Wellness or not?
No, I'm not sure. Sorry.
So I'm sorry, we can't address that one. Any ideas on when the borders out of Botswana will open? I'm afraid I have no say in that whatsoever, so I'm not even going to try and comment. The death rate in Botswana is quite low. Why is this? Well, thinking about that, at the moment, as of now, we've got 2,463 cases. Of those, 1,350 are local cases, and 1,113 have been transferred out of the country. So of our 1,350 local cases, we've had 11 deaths, which leads to a case fatality rate of 0.8%. And that's actually fairly much in keeping with what the emerging data is showing. So what we'd expect, based on what's happening in other countries, is an infection fatality rate of somewhere between 0.3 and 0.6%. And certainly it does seem that many African countries are at the lower end of that, which is almost certainly due to their age breakdown. There's a much lower proportion of patients over the age of 50, and particularly those at highest risk over the ages of 60 and 70 in our population, compared to, say, Italy or the UK. So that age breakdown does make quite a difference to the overall mortality rate. In terms of other reasons, it would be pure speculation. It's not clear. There's some discussion about other coronaviruses, pre-existing immunity, but I think that probably that's not going to come to pass. I think it's purely a function of the age structure, and also in many settings, probably a function of underreporting because there aren't good structures and systems in place. Are healthcare workers who test positive supposed to keep working or self-isolate? So there is a guideline which you can look at in that on the web, as I showed you, specifically about healthcare workers. But no, if healthcare workers test positive, then they need to isolate. As per the guidelines I've just outlined, that's particularly important because we don't want them infecting other patients. Are there individuals who've recovered and get reinfected with coronavirus? And if so, is it the same strain or a different strain? Well, the world has now had many millions of cases of coronavirus, and as yet there are almost no examples of confirmed reinfection. There have been a couple of cases where somebody has tested positive again, having tested negative, but it's unclear whether that's a proper reinfection or whether it's just some shedding of the dead virus. I think there have only been 3 or 4 cases convincingly reported. Several of them were very well patients, and only 1 or 2 have been sick. So it still seems very unclear whether you can get reinfected. Certainly, we're only 6 or 7 months into this, really. So, of course, maybe a year later or 18 months later, that might be possible. We just don't know. But certainly within the time frame that we've been at so far, reinfection is very, very rare, and I think unlikely to be a major problem. Have we started the process of coexisting with COVID? If so, what measures are needed? Well, that's a difficult question. I think that one thing we can be fairly confident about is that coronavirus is not going to disappear, that we're not going to eliminate it as a disease from this planet. The chance to do that has gone, so it is going to be here and we're going to have to live with it. I think we're going to carry on seeing much of the same for the remainder of this year and probably the first half of next year. And I think the thing that will really change the picture is when we have an effective vaccine, which moves on to the next question. Are we in a position to do clinical tests with, they've asked about the China vaccine or any vaccine. The answer is we're not, to my knowledge, involved in any vaccine trials yet, but I'm sure that when vaccines do become available, we will try and ensure that we are involved in those trials and have access to the vaccines. Now, I don't quite understand the next question. I'm just going to skip open that. Do you plan to open drive-through testing checkpoints in Gaborone? Well, I can't answer on behalf of the ministry. The Botswana-Harvard Partnership is going to start doing a study where we'll be doing some community testing, where we'll be going into communities trying to find symptomatic individuals and offering options like drive-through testing for symptomatic individuals in the community to get tested. That should be happening in the next month or two. I'm not sure what the plans are nationally. Has Botswana ever recorded a severe case of COVID-19 so far? Are there any treatment protocols in place yet? So the answer to that is yes and yes. There have been severe cases recorded and treatment protocols are in place. As I've run through, they're in the clinical care guideline. But maybe at this point I could hand over to Dr. Pillai to comment on that. And I don't know if Professor Farai, who is running the ICU at Sir Ketamile Masire, is also on the line. He could maybe comment as well. But Dr. Pillai, could you just address that point for me?
So yes, we have dealt with very severe cases, and we currently have one case that intubated, but we've had cases that have come into ICU requiring either high flow nasal oxygen or cases requiring rebreather mask with sort of shaky saturations. But so far, all cases that the first case that we had intubated in the early August was actually extubated after 38 days, about 2 weeks. It continues to do well. We've since transferred that patient, I think, today to Princess Marina. He's actually recovered. He's tested negative twice for COVID now.
Great. So thanks, Dr. Pillai. So I think the answer is yes, we have seen, these severe cases as Dr. Pillai has just outlined. And of course, I think we anticipate seeing many more, unfortunately. Has the coronavirus case definition changed now that there's local transmission? Well, we've been through that. Effectively, the definition hasn't changed, but given that there is now local transmission going on in almost all locales, it means anybody with the symptom profile consistent with coronavirus should be a suspect case. How far is the coronavirus vaccine? So people have probably read about several of these vaccine trials. There are now several vaccines in phase 3 trials, which are the final phase of trials before they can be given to large populations. The most advanced of these is something called the Oxford vaccine. The trial was recently stopped because of an adverse event of transverse myelitis in a patient, but has been restarted. And there's hope that there'll be results from that trial towards the end of this year. There are several other vaccines being trialed in America, in Russia, in China. Russia's started actually giving its vaccine, although the data to support that is very limited. It's not yet been in proper clinical trials. China have several vaccines which are at advanced stages of development in phase 3 trials, and they're routinely vaccinating their military and frontline healthcare workers with some of them already, but we're awaiting the data from the phase 3 trials. So I think that we will have the first good evidence from phase 3 vaccine trials towards the end of this year and early next year. But of course, that doesn't mean that a vaccine is going to be available, because first of all, we have to have trials that show a successful result. And of course, we don't know whether that is or isn't going to be the case until the vaccine trials report. And even if we're extremely lucky and the first vaccines that they've developed prove to be highly efficacious, which is not necessarily likely, it still takes a considerable amount of time to scale up production when the whole world needs this vaccine and they're going to have to produce 7 billion doses. So I don't think that we'll be seeing most of our patients or most of us getting vaccinated until at least the middle of next year to the end of next year at the earliest, but I may be proven wrong. How long does it take to develop antibodies after infection? Well, we've talked about that in the talk. You can't reliably detect antibodies until 5 to 7 days after symptoms develop. How long will it take in terms of years for Botswana to go back to pre-COVID state of affairs, health-wise and economy-wise? Well, I'm not an economist. I won't even begin to comment on that. But health-wise, as I've said, I think we're going to be in some state of coronavirus control and restricted social movement, distancing, and so on until at least the middle of next year, possibly longer. We've been through the new guidelines. We've talked about isolating patients at home and what the criteria are for that. I think that, let's see, Robert, I mean, and Gontse, there are a lot of other questions. I wonder whether anybody has any questions, you know, just mindful of time, specifically for Drs. Milburn and Ryan or Dr. Pillai about the clinical experience, and particularly about the clinical experience of looking after these patients in hospitals in the UK or in the intensive care setting before I carry on going through this list.
Hello, anyone from the audience with questions that they want to pose to the team, you can raise your hand. Anyone with a burning question that they want to? Okay.
Hi, Gontse. It's James Milburn here and Becky Ryan.
Okay.
We've got a couple of comments if people are interested, a couple of things we picked up whilst we were in the UK, and perhaps that might give time to for people to think of any further questions, if that's helpful.
Okay. That's okay.
As already said, excellent talk by Professor Jarvis, and not a huge amount to add, but a couple of things that we've seen whilst we've been in the UK is how some of these patients present, and I thought it might be helpful just to touch on a few of the areas outside the sort of case definition itself. So alongside what's been described of the sort of upper respiratory tract or lower respiratory tract syndrome, a lot of our patients have been describing anosmia, which I think is an important symptom to recognize that can be associated with COVID, either that or a change in the sense of smell and the sense of taste. And we've also been seeing that a lot of our patients have quite a similar clinical course when they present. So picking up on the timing of their symptom start is important, because actually a lot of the patients tend to deteriorate between sort of day 7 and 10. And that's often when patients who are being managed on the ward ended up needing either non-invasive ventilation or being transferred to ITU for sort of a higher level support. So I think when people are being admitted into hospital, it's really important to recognize when their symptoms started, because later on that can help you predict when perhaps they might start to deteriorate. Obviously, it's not exclusive that everyone deteriorates in that time frame, but it can be quite a useful guide for some of our patients. And the other thing we saw a lot of in the UK were clots, so DVTs, and Ps, and I think examining your patient carefully for these is really important. So there's quite a lot of literature out there showing that COVID is very prothrombotic, and a lot of the patients who were being managed as an inpatient developed either DVTs or PEs. And so examining your patients daily to look for these, and also looking for line-associated DVTs as well if they've got any central access, is really, really important. And in addition, we saw things like strokes and STEMIs and other MIs, all in the context of COVID and a sort of a prothrombotic state. Professor Jarvis mentioned X-rays and sort of what the typical features might be. And what we routinely saw was perhaps what you'd expect with a atypical pneumonia, with sort of patchy bilateral peripheral changes predominantly, but not exclusively in the lower lobe. But it's really important to recognize that early in the illness, a lot of patients might have a clear chest x-ray, as well as the negative swab that also we see in about 20% of patients. So a compatible clinical syndrome and a good history is really, really important. I think those are sort of some of the key points that we flagged up, but we're happy to take any further questions if there's anything else.
Thank you, Dr. James, for that. Do we have any questions from the audience? Because I can see that we are beyond our time. But if there's any questions that somebody wants to ask, we can ask before maybe we refer back to the team to answer some of the few questions, because I don't think we are going to be able to answer all the questions because we are running out of time.
Dr. Kapanda, you can ask.
Sorry, there was a question that just popped up from Justice about routine or selective anticoagulation. So we gave prophylactic dose Clexane, which I believe was 40 milligrams, to basically everyone with COVID. Those patients who are needing higher levels of care, we gave a augmented dose, which was 40 BD to patients who were needing either NIV or mechanical ventilation. And even in the cohort of patients that were mechanically ventilated and had augmented DVT prophylaxis, or VTE prophylaxis rather, we still saw 30 out of a cohort of 190 develop some form of VTE, either associated with a line or a PE or DVT.
Yeah, so thanks, James. And if I can just add to that, that's effectively what our guidelines say here as well, everybody. So Tommy, do you want to just, Dr. Pillai, do you want to just add a little about what you're doing in terms of anticoagulation?
Yes, so for all patients, definitely, with moderate to severe disease, we give therapeutic Clexane, which is 1 milligram per kg twice a day. We do have selective patients that will be symptomatic but not requiring oxygen and have underlying comorbidities, which we've seen quite a lot in our patients who then progress to require oxygen. Patients with diabetes, patients with hypertension, chronic kidney disease. So some of these kinds of patients will also give therapeutic Clexane just to decrease their risk of progression. Otherwise, most of our patients, we give them prophylactic Clexane. Some patients do turn it down and tend to do well, but some do agree, and if they do, we do give them that. Thanks.
Great.
Dr. Kapanda, you can ask.
Yes, thank you very much. I just wanted to ask out of curiosity if at this point is anything known in terms of interaction between HIV and COVID-19, whether even in terms of patients, whether there are more complications, or in terms of therapy, the fact that most patients on HIV patients are on antiretrovirals, do they have any kind of protective effect against COVID? Thank you.
So thank you, Dr. Kapanda, for that. It's a very good question. The best data we have now come from a large cohort in South Africa, which is, of course, really the first country with a high or large population of HIV-positive individuals who've been getting coronavirus. And what the data suggested from the Western Cape in almost 28,000 patients is that HIV-positive patients do have an increased risk of mortality from coronavirus. In fact, it was almost a twofold increased risk, so quite significant. And that was independent of viral load. So even in individuals who were on antiretroviral therapy and virologically suppressed, they still had an increased risk of severe disease and poor outcomes, which of course is not fantastic news for our setting and our patient population. And it certainly doesn't suggest that there's any protective effect of antiretrovirals. And lopinavir ritonavir has now been comprehensively tested and shown not to have any benefit. There was some talk about tenofovir potentially having an effect, but that's based on it's not even in vitro model work, it's totally theoretical. So I don't think there's any suggestion really that, antiretrovirals will be protective. Shall I carry on with addressing some of the questions in the chat and on the from the pre-written questions, Gontse?
Yes, please.
Yeah.
Thank you.
Fine. So a few questions. So why is the quarantine period 14 days when the virus is deemed dead at 10 days? So just to reiterate this, quarantine is not for people who actually have infection. Quarantine is for people who've been exposed to somebody who's infectious. And of course, there's an incubation period from when you're exposed to when you start to shed virus, and a period of time from after you start to shed virus to when you become symptomatic. So the 14-day period is designed to capture that and ensure that we're catching anybody who's been exposed, who's then developing infection and becoming infectious within that 14-day period. Rather than isolation, which is somebody who's got infection and will stop shedding the live virus after 10 days. There's a question about antibody testing, serological testing, particularly in the context of pediatrics and pediatric inflammatory multisystem syndrome, or PIMS. So yes, although serology has not got a role really in diagnosis, it may have a role in that setting. And yes, we do have serological testing available at the Botswana-Harvard partnership. So we've received a donation of quite a large number of serological test kits. So I think it would be on an individual case-by-case basis, but if pediatricians want to access serology testing, then they should contact the Botswana-Harvard laboratory to discuss that. What are the current home quarantine guidelines? Well, at the moment, the guidelines are still favoring institutional quarantine for all contacts found through tracing. The Presidential Task Force and the Ministry of Health team are trying to develop some technologies and trackers that patients can wear so they can ensure patients can adhere to home quarantine. So home quarantine is generally still not favored, but if it's assessed to be safe in specific cases, it will be allowed, and especially in the context of minors where they don't want to be, there are concerns about facility quarantine, minors will be home quarantined. Let's have a look back through what could be the way forward as cases are escalating. Well, I think that's a difficult question, but you know, as the epidemic's progressed, we have learned more and more about transmission. Of course, effective contact tracing and quarantine plays a very important role in isolation of cases to prevent transmissions. But also it's clear that the risk of transmission is driven very much by close contact in closed, confined spaces and for long periods of time. So effectively, I think we should very much be focusing on avoiding situations where large numbers of people are gathering together in close or confined spaces for large periods of time to prevent any super spreading events from happening. At the moment, the guidelines are relatively relaxed about that, but I suspect they may need to be strengthened in terms of things going forward. For example, in the UK, they've just put in place a rule of 6 where they've banned gatherings of more than 6 people. And I think that if our cases continue escalating, that kind of intervention may need to be considered here. Let me just see what other pressing questions are in this list. There are quite a lot of questions about the role of the private sector in all of this. I have to say, I'm afraid I don't think I'm best placed to respond to that. Of course, many of the guidelines that we've written are as applicable to the private sector as they are to the public sector, particularly regarding PPE, triage and assessment, isolation and cohorting of patients, and how testing can be organized. So hopefully looking at those guidelines, it would be useful. Any other questions? Wearing masks, would it be reasonable to suggest all hospital patients wear masks? Well, I think certainly if you suspect somebody of having coronavirus, then yes, you should give them a mask to wear while you're working them up and trying to determine what's happening and getting them to an isolation unit or cohort area. But of course, once patients have coronavirus and they're cohorted together, then it doesn't really matter so much. Certainly, I think healthcare workers should be fairly much universally masking in the hospital these days to protect themselves from coronavirus whenever possible. I'm conscious of the time, Gontse. We're now 10 minutes past. Do you want me to continue, or do we need to wrap up?
Maybe continue for the next 5 minutes, please.
The next 5 minutes.
Yes.
There are studies from Northern Europe that may indicate that other coronavirus infections like the yearly URTI may protect against this viral disease due to antibodies. What's my opinion on that? Well, I think that as of yet, I've not seen any convincing evidence that cross-protection from other coronaviruses plays any role in this epidemic and in transmission. But I also think that we don't yet have the data to make a conclusive statement on that. Certainly, there are some, there is some theorizing, particularly in South Africa, say, where the mortality rate's been slightly lower than might have been expected, given the number of cases, that could play a role, but I think that's very much open to debate. If there is an effect, it's clearly not a large effect, given the way that epidemics have behaved in all sorts of different settings and countries. And in terms of children, they do get frequent respiratory tract infections. They may be more likely to have these antibodies. The data do suggest that children don't get such severe disease and infection, but they still do get infected and shed virus for certain. What are my comments about the epidemiology of coronavirus in Botswana? Northwest Districts had very few cases. It's a slightly difficult question to address. I think what we're seeing is probably what we'd expect and what we've seen elsewhere, that coronavirus, the rapidly expanding epidemics tend to happen in densely populated urban centers where there are lots of people around to facilitate transmission. That doesn't mean, of course, that it can't happen in more sparsely populated and rural settings, but I think you're less likely to see explosive epidemics outside of urban centers where there are lots of people working, living and traveling together than in more rural areas. And of course, the other thing is about, introduction of infections and where the infections actually are. And I think Gaborone has very much been the focus, because we probably had a small epidemic that wasn't completely contained during the initial lockdown from introduced cases from overseas. And secondly, of course, many of the truck drivers and delivery drivers who've been coming in, one of the main stops has been Gaborone. So that might explain some of the difference. Let's just see which other questions, any other key questions. I think I've addressed, at least in part, most of the other questions which are sitting in the inbox. So I may hand it back to the chairs at this point and just ask them if there are any other pressing questions or if they want to wrap up the session.
You have just 2 minutes for any burning questions, because I had requested for 5 minutes, so I still have 2 more minutes. Any burning question? Anyone from the audience, or we wrap up the session?
There's also a question in the chat box, the last one, which is talking about self-isolation.
Or the one from Dr. Shalashando.
So maybe, David, Lawrence, David, can I just ask you, I'm trying to remember what we ended up putting in the guideline about that self-isolation period of 14 days after discharge. Can you remember?
Yeah, so when we wrote that initially, that was before the period of extreme social distancing, and also without knowing exactly how long that would continue. So what we expect of all of those that have recovered is that, for 14 days after they've been released from isolation, to follow that guidance of wearing a mask, socially distancing, minimizing interaction with others, hand hygiene, cough etiquette, all of those things. But obviously, with the extreme, so we're all doing that. So for those 14 days, we're all doing the same thing anyway. So those individuals, when they have been released from isolation, they are able to go back about their usual duties if they're a healthcare worker or any other member of society.
Yeah, and I think broadly speaking, it's just being extremely cautious. You know, as you've said in the question, yes, we expect the virus to be dead certainly by day 10. So it's probably not necessary, but it's just being extremely cautious. And as David's outlined, it relates to what everybody should be doing anyway now.
May I ask a question?
Go ahead, please.
Thank you. Professor Jarvis, what do you think the impact is going to be of South Africa opening its borders or relaxing the restrictions at its borders on the 1st of October? And I think similarly, Zimbabwe is also reopening to international travel. What do you foresee happening here as a result? And this issue about having to take PCR certificates to get across the borders. Thanks.
Yeah, no, so that's a fairly difficult question, Shananda. So South Africa have suggested that they'll be opening their borders on the 1st of October. They've yet to release the country list from which they will be accepting travel, to my knowledge. So I'm not terribly clear on the details. But I think that it also then depends, of course, on what the Botswana Ministry of the Presidential Task Force and the Botswana government decide about their borders, because of course it requires both the Botswana border and the South African border to be open for there to be free travel between here and South Africa. And I don't know what the outcome of that will be yet, but I suspect South Africa, although their epidemic is certainly declining, they still have significantly more cases than here. And I think that allowing free movement of people between South Africa and Botswana is certainly a fairly high risk exercise for Botswana. So I would probably imagine that travel restrictions will remain broadly in place for the moment. I also suspect that as case numbers are rapidly increasing in Europe, with France and the UK almost back to some of their levels that they were seeing earlier this year, and the US having a broadly uncontrolled epidemic, that South Africa will be very reluctant to allow travel in from Europe and the States into South Africa. So in terms of that international travel coming via South Africa to Botswana, I think that will remain very contained. In terms of getting tests to enable travel, I'm afraid I do not know the answer to that question. Although what I would say is that testing well people who want to travel for non-essential travel reasons will probably be low priority for the testing centres when they're trying to keep up with testing sick patients presenting to hospitals and those being contacted through contact tracing to control the epidemic. So I'm not sure how that will happen.
Thank you.
Okay, thank you, Professor Jarvis and the team. May you please respond to Dr. Mbenge's question? That's the last question. The reason why I'm bringing it is I know that she's been asking this question for more than a week. Probably she never got the answer. That's why she's asking it now. About truck drivers.
Truck drivers. So for recovered truck drivers who do cross-border travel and persistently test positive, how to interpret results and manage them? Well, that's a very difficult question. So as we did touch on briefly in the talk, you can shed the viral RNA, which can be detected by PCR testing for many, many weeks, 4 or 5 weeks after initial infection. So if somebody keeps persistently testing positive, it probably means that you're just detecting dead virus. But broadly speaking, given the difficulties of tracking that and tracking who's tested before and is now testing positive again, I think the likely way of dealing with it is to just maintain that any positive truck drivers will be placed in quarantine and not allowed to travel through the country, just given the logistical difficulties of trying to figure out, well, are they now not infectious? How long is it since their first test? Just given the sheer number of truck drivers coming in and out, I'm not sure that the capacity is there to make those individual level decisions. So likely they won't be able to travel until they test negative.
So, Joe, just in addition, we've actually dealt with about 6 cases like that. So what usually happens is we contact Dr. Moyo, who gives us the CT values. We look at the first test, and we are actually able to make a decision on whether the truck driver must be kept in 72 meal and quarantined again. And one of the main factors we look at is that truck driver who, example, tested on the 1st of August and was deemed to have recovered, comes back in the middle of September, which is 6 weeks later, symptomatic. That's the first question. If they are asymptomatic, we've contacted Dr. Moyo, we've looked at CT values and risk of infectivity, and we've in fact not kept those truck drivers in conjunction with the task force. So for those that do test positive, we encourage the DHMT to discuss the interpretation of the results with us and actually involve Dr. Moyo.
Thanks very much, Dr. Pillai. That was interesting, helpful.
Okay, I think we have to wrap up now. We have to close the session. Thank you so much, Professor Jarvis, for the excellent presentation. And thank you, the team, Dr. James, Dr. Pillai, Dr. David, for your input. I can tell this presentation was long overdue because I'm sure that most of the questions, some of the questions were not addressed because of the shortage of time. And also, our participants, I think I want to thank you also because without you, there won't be any webinar, and you've been very patient. We've went beyond time, but you are still here. So thank you so much. And we will announce the days for the next webinar sessions through your email. So if you want to join the emailing list, please email armumakwa@yahoo.com. So once again, thank you so much. And thank you, Rutgers Global Health Institute, for making this online meeting possible.
Thank you very much, everybody. Bye-bye.